Hello, this is Cardiology for you. I'm Associate Professor Yana Simova, and today we are going to speak about a very tricky topic, and this is the differentiation diagnosis between constrictive pericarditis and restrictive cardiomyopathy. Why is it so important to make this diagnosis? Because both conditions are relatively common and associated with increased morbidity and mortality. Also because constriction could be healed with cardiac surgery while restriction could not be healed. But why is it also so difficult to distinguish between constriction and restriction? Because both conditions have similar clinical pictures. The hemodynamic changes are also similar, and the main pathophysiological characteristics is the impaired diastolic feeling. So the main thing to remember that could help us to distinguish constriction from restriction is that constriction is the disease of the pericardium, while restriction is the disease of the myocardium. And therefore, in constriction, we have reduced pericardial compliance with normal myocardial compliance, while it's vice versa in restriction. Here we have normal pericardial with reduced myocardial compliance. And therefore, in constriction, we have the early diastolic feeling is not impaired, while in restriction the feeling is impaired throughout the whole of the diastole. Also very important thing is that intrathoracic pressure is not transferred to cardiac chambers in constriction because of the diseased pericardium, and it is transferred to cardiac chambers in restriction. The first one to describe the unique pathophysiology of constrictive pericarditis was Liv Heitel. He described the dissociation between intrathoracic and intracavitary pressures and also the increased interaction between the left and the right ventricle. Let us see how does this happen. In constriction, during inspiration we have a decrease in intrathoracic pressure that leads to increasing the flow through the tricuspid valve and into the right ventricle. Because of the decreased space which is due to the constricted pericardium, the septum bounces, shifts to the left and decreases the filling of the left ventricle. Another thing that decreases the filling of the left ventricle is the decreased gradient between the pulmonic veins and LV and diastolic pressure, because again the intrathoracic pressure, its decrease could not be transferred to the left ventricle. The opposite changes happen during expiration, but in restriction we do not have such respiratory variation, because here intrathoracic pressures could be transferred to intracardiac pressures. So, to diagnose constrictive pericarditis, we have to demonstrate the high ventricular filling pressures, but which is also common for constriction. But also we should demonstrate the dissociation between intrathoracic and intracardiac filling pressures and exaggerated ventricular interdependence in the diastolic filling. So constriction could be diagnosed and should be differentiated from restriction using multimodality imaging, mainly with echocardiography, but also with CT, chest X-ray and MRI. And when the diagnosis is still not reached with these non-invasive methods, then a cardiac catheterization should also be performed. So let us start with echo. It would be very very easy. If we could see a pericardial thickening during echo, it is more easily seen with transesophageal and less easily seen with transthoracic echocardiography. You could see it here. A pericardial thickening of more than 3 to 5 millimeters is very specific for constriction. But normal pericardial thickness does not exclude constrictive pericarditis, and in this large study from Mayo Clinic you can see that in 143 patients with a proven constrictive pericarditis and subjected to pericardiectomy, nearly 1/5 of them have normal pericardial thickness. Another echo finding, which is typical for constriction and could be seen with the M mode imaging, is this septal bounce in early diastole or with atrial systole. Also in the posterior wall of the left ventricle you could see the upward-backward motion in early diastole, followed by a flattening and lack of motion throughout the entire part of the diastole. With 2D imaging, you could see the typical respiratory septal shift, that is the difference in the maximal septal excursion into the left ventricle between expiration and inspiration. It happens in early diastole during inspiration when there is an increase in RV and a decrease in the airway filling, and you could see the bounce of the septum towards the left ventricle. The M mode characteristic of this septal shift, you could see it here, the typical dropout of the septum towards the cavity of the left ventricle, which happens only during inspiration. A common finding between both conditions is that inferior vena cava is dilated and with minimal or without respiratory changes. Another very useful sign that could distinguish constriction from restriction is the Coward M mode and the M mode propagation velocity. As I have said, constriction is a disease of the pericardium, so the early diastolic function is not impaired, and the relaxation here is not impaired. So we have the propagation velocity, which is usually normal, and values more than 100 centimeters per second are very specific for constriction. While in restriction, which is a myocardial disease, we have a decrease in diastolic function throughout the whole diastole, and therefore we have also impaired relaxation of the left ventricle with reduced propagation velocity, and the value here of less than 45 is typical for restriction. The mitral valve inflow could seem very similar in both conditions, with the high E wave with the E to A ratio of more than 1.5 and shortened deceleration time of less than 160. But if we see it in detail, then we could see the typical pathological respiratory variation of the mitral inflow in constriction that is not typical for restriction. What does this mean? It means that we have a more than 25% change in the velocity of the E wave, with an increase of the E wave during expiration and a decrease during inspiration. We should bear in mind that around 50% of the patients do not have such pronounced pathological respiratory variation. In these patients, we could ask them to dip more briefly or to sit up in bed in order to reduce the preload of the left ventricle, and so to be able for this pathological respiratory variation to become more obvious and that we could see it. In restriction, we don't have respiratory variation. So, this pathological respiratory variability of the mitral flow could also be seen in several other conditions such as COPD, asthma, sleep apnea, and obesity. How could we distinguish the COPD from constrictive pericarditis? It could be very easy with the flow in superior vena cava. In COPD, we have an increase in flow during inspiration, while in constrictive pericarditis, we have very minimal respiratory changes. And still, speaking about the left heart chambers, let us see what is the respiratory variability in pulmonary venous flow. It is similar to that through the mitral valve, with an increase in S and D velocities during expiration. But here the D velocities increases more than S velocities during expiration, and so we have a decrease in the S to D ratio during expiration. And now let's go to the right side, and here the flow through the tricuspid valve. It is opposite to that of the mitral valve, and here again in constriction we could see the pathological respiratory variation with a more than 25% increase in the velocity of the E wave during inspiration and decrease during expiration, which could be seen in constriction and is not present in restriction. Also, talking about the right heart chambers, we should say a few words about hepatic vein flows, which are very useful for the differentiation between constriction and restriction. In constriction, we have an increase in the reflux during atrial contraction and appearance of ventricular reflux during expiration, while in restriction we have an increase in the reflux during atrial contraction and appearance of ventricular reflux only during inspiration. Another very useful thing to differentiate constriction from restriction are the tissue velocities. So, as I have said, restriction is a myocardial disease, and therefore tissue velocities are decreased throughout the myocardium. So we have a decrease in the septal E prime velocity, which is less than 7 centimeters per second, but the ratio between septal and lateral E prime velocities is preserved, with septal E prime lower than the lateral E prime. What happens however in constriction? Here it is a pericardial disease, so the myocardium in the septum is not diseased, and we have a normal E prime septum velocity of more than 7 centimeters per second, and we have a reversal of the E prime velocity ratio between the septum and the lateral wall. Why is it so? Because the lateral wall is adjacent to the diseased pericardium, and the velocity of the lateral wall suffers from the diseased pericardium, and so E prime is reduced because of the diseased pericardium, and this is the so-called annulus reversus phenomenon. Let us see it again. In the normal condition, like here, we have lower E prime velocities in the septum and higher velocities in the lateral parts of the heart, namely the lateral mitral annulus and free wall of the right ventricle. In restrictive cardiomyopathy, which is a myocardial disease, we have a decrease in all tissue velocities, but the ratio between them remains the same. While in constrictive pericarditis, The myocardium in the septum is not influenced, so we have a normal E' septal velocity, but we have a reduction in the E' velocities there where the myocardium is adjacent to the diseased pericardium, and that is in the lateral part of the mitral annulus and in the lateral and the free wall of the right ventricle, and this is the typical annulus reversus phenomenon. Also very useful thing is the speckle tracking and strain imaging. In restrictive cardiomyopathy, which is a myocardial disease, we have an overall reduction of myocardial strain, which is also very typical for the septal region, while in constriction we have a preserved septal longitudinal strain, while we could have a decrease in the longitudinal strain in those areas which are adjacent to the diseased pericardium. So let us say what were the common things in constriction and restriction. Regarding the mitral inflow, we have the increase in the E wave velocity, the E to A ratio of more than 1.5, the decrease, deceleration time usually less than 160. Regarding vena cava inferior, we have dilated vena cava with reduced or absent respiratory curves. What are the main differences between them? We have the septum valves in constriction, we have the annulus reversus in constriction with a normal E' velocity in the septum, but reversed relation between lateral and septal E'. We have, however, a reduced E' with restrictive cardiomyopathy in the septum, but with normal relationship between lateral and septal E' in restrictive cardiomyopathy. Of course, we have also these respiratory changes which are more pronounced and pathological in constriction through the mitral valve, tricuspid valve, and in the hepatic flow and in the hepatic veins, and they are not present in restriction. Also, the septal strain is typically very reduced in restriction and usually normal in constriction. Biatrial enlargement is much more pronounced in restriction and not so pronounced in constriction. Pulmonary hypertension is also more pronounced in restriction and not so much in constriction, and more often we have mitral and tricuspid regurgitation in restrictive cardiomyopathy compared to constrictive pericarditis. We have also a subset of a mixed physiology where there is a well-defined entity characterized by a localized pericardial thickening, as you see here, accompanied by restrictive feeling but without significant respiratory variation. It should be said that those patients who have the mixed constriction and restriction have reduced survival compared to patients with constrictive pericarditis only. So the other imaging methods, the chest X-ray, it could be very useful if we have pericardial calcification as a diagnosis of constrictive pericarditis, but you should know that in only 1/4 of the patients we have such pericardial calcification, and the absence of such a finding, of course, does not rule out constrictive pericarditis. CT could be even more useful in demonstrating pericardial calcification and the thickening of the pericardium, while MRI could be very useful in differentiating different types of restrictive cardiomyopathies, such as in this example, a patient with a cardiac amyloidosis. If we still don't have a definite diagnosis by the imaging methods, we could come to the catheterization. The common findings in constriction and restriction are these deepened plateau or square root sign. What is this? This demonstrates the early and very fast diastolic filling enhanced by increased suction of both right and left ventricle, and then the abrupt cease of the filling, which is limited by the pericardium in case of constriction or limited by the myocardium in cases of restriction. These were the common findings. What are the differences? The traditional hemodynamic criteria to distinguish constriction from restriction are the following. In constriction, the LV and RV and diastolic pressures are relatively similar, and the difference between them is no more than 5 millimeters of mercury. Also, we have a not so high RV systolic pressure, which is less than 50, and therefore RV and diastolic pressure is more than 1/3 of RV systolic pressure. What we have in restriction, there the LV and diastolic pressure is more pronouncedly enlarged compared to RV and diastolic pressure, and the difference between both is more than 5. Here also RV systolic pressure is much more higher, and in these cases it is very often more than 50 millimeters of mercury, and therefore the RV and diastolic pressure is less than 1/3 of RV systolic pressure. However, I should say that these typical hemodynamic criteria have low real clinical value, and therefore there is a search for new hemodynamic criteria which could be derived from the respiratory changes in RV and LV pressures during inspiration and expiration, and such an index is the systolic area index. This is the ratio between two ratios. The first ratio is the ratio between RV area and LV area during inspiration, and the second ratio is the one between RV area and LV area during expiration. You could see that in constriction, because of this respiratory variation, there is a large change in this ratio between inspiration and expiration, and therefore this psi index is more than 1. It is even more than 1.1, and this is very typical for constriction. These ratios are very similar in restriction, and there the psi index is around 1. So including the psi index in this algorithm for invasive evaluation and differentiation between constriction and restriction, we reach a much more high indices of sensitivity, specificity, positive and negative predictive values for the differentiation between constriction and restriction. So at last I would like to tell you about the ACE and EACVI algorithm for differentiation between constriction and restriction. It starts first with the evaluation of mitral inflow and inferior vena cava. If the E to A ratio is less than 1.8 and vena cava inferior is not dilated, then constriction and restriction are very unlikely. If these conditions are met, we proceed to search for ventricular septal motion abnormality with respiration. If we find such a thing, we evaluate the septal E prime. If it is less than 8, then it is constriction. If it is less than 6, then it is restriction, and if it is in between 6 and 8, then we may have mixed constriction and restriction, or we should proceed to further evaluation, which could be the search for the annulus reversus phenomenon. If we find it, it is most likely constriction, and also we could search for the change in hepatic vein flow during respiration, which could be very typical and could be definite for constrictive pericarditis. So my take-home messages to you are that constrictive pericarditis and restrictive cardiomyopathy result both in diastolic heart failure with similar main echo features, but totally different pathophysiology and management. Every patient with predominantly right-sided heart failure and suggestive history should be evaluated for constriction and for restriction. Usually, echo could in most cases clearly distinguish between these two conditions. However, in some borderline cases or in cases with unclear diagnosis, additional tests could also be necessary, such as imaging methods like CT or MRI, or even cardiac catheterization. So this was all for me for now for this tricky topic. I hope that the things that I have shown to you has been useful in some way to make the differential diagnosis between these two conditions a little bit more easy for your clinical practice. If you feel that this information has been useful to you, you could share it with your friends, with your colleagues, and in other social networks. Thank you very much for your attention.